Hey folks, Scott Weingart here, and this is an EMCrit We. Now, the topic of today's We might seem a divergence from our normal episodes. We're going to talk about opioid harm reduction and opioid adulterants. And you're like, that's not resuscitation or critical care. Well, with the new crop of adulterants like medetomidine, it actually is critical care. These patients will be coming to the resus area of your ED, and they very well might need ICU admission in many cases. So this is directly relevant. But I still, even if they weren't sometimes sick patients, I still think this is an important topic. So this is the first of 3 episodes on opioid adulterants. And so now this is a diversion from the normal stuff. This is not the path I'm going. I'm not becoming like my buddy Ruben Strayer and just moving to opioid harm reduction. Don't worry. It's all going to be resus and critical care after this. But this is an important topic that I wanted to delve into. So this first episode is with Courtney Doherty, who is a harm reduction specialist and an FTIR technician. That's Fourier transform infrared spectroscopy. It's a way of analyzing drug samples to see what adulterants are in it, what actually is the makeup of that drug that you think is heroin or fentanyl, what actually it's been cut with. And she has insights into the drug system, into all sorts of pieces that you'd only get from someone who is in the street talking to the people who are actually using. And she has a harrowing history detailed on her TikTok channels. It's really an amazing story. We're not going to get into that stuff on this episode. What we're going to talk about primarily is the nituses of drug adulteration, why it happens, what current adulterants we're seeing in the opioid supply, and then a little bit of discussion on harm reduction. So it's a super fun interview. Check out her TikTok channel. She's doing a great job talking about issues like homelessness, drug adulterants, opioid use, etc. So I was really happy to have this. The following episodes, we're going to have a medical toxicologist talking about the management of primarily medetomidine adulteration, and then we have an anesthesiologist from Europe talking about the nitazines. And so look forward to this stuff. If it's not your bag, then just don't listen to these 3 episodes. But I think anyone in emergency medicine really needs to know all of this information. So let's get right to it. So we'll start off with the same question I ask everyone. Who are you and what do you do?
I'm Courtney. I do TikTok content creation, but I'm also an FTIR technician at St. Anne's Corner of Harm Reduction. So I started working there as a harm reduction specialist about 3.5 years ago. And then I moved on to doing FTIR technician work. So I basically test substances that people bring in, and I study the drug market, the drug supply. I do trend predictions, and I work with public health sectors to teach them about what's in the drug market and how to better prepare public health, like alerts and things like that.
Yeah. So tell me a little bit more about this. I'm super curious. So FTIR, you're primarily doing, it's a truly technical way of breaking down the drugs to figure out what other potential adulterants and cutting agents and all that are in it. How much of your work is on a machine and how much is doing harm reduction at a more sociological level?
I would say it's really 50-50. So like the technician aspect, I'm on the machine. When I get a sample to test, when a person brings me the sample, I need to have enough drug knowledge and enough like social knowledge and trust level with them. They know that what they're bringing me is anonymous. They know that when they're bringing it to me, there is no judgment there. There's no stigma. I just want to know what they're bringing me, like what it was bought as, if it was bought as crack, if it was bought as meth, because that helps me understand the analysis of it. If something pops up that's unexpected, I need to make note of that. And then I also ask them about any effects associated with it, like why they want to test it. Some people test everything they get. Some people just want to test it because they had an adverse reaction. And that also helps me because if I see a component in it and then I hear the adverse reaction, that allows me to build like what components might be causing some adverse reactions. And that will help us build better healthcare systems and better public health systems to better understand what people are using and the effects that it has. Studying the substance is entirely on the machine. There's a lot of social aspect there as well.
This is just so cool. I didn't even know we'd get into this aspect of it. But so how does someone on the street even find out there is a you to come in and bring their product to?
It's mostly word of mouth. The legality of it is gray right now. We mostly just do it word of mouth. I work at a harm reduction center, so we advertise that we have this like service available among 25 other services that people can use. So a lot of people have known me for years through working there and being in the community. They know that I do that, so they know to come to me. And also just word of mouth on the street. It's talked about among people who use drugs, oh, I got this tested and this was in it. You should stay away from it. Or I liked it. And then they go tell other people about it, and then they hear about it and they might be interested to come in as well.
Now, you're in the Bronx, and the Bronx are a harbinger of what's going to be eventually in the rest of the city. That's, I think, ground zero for the new products coming in.
Yeah.
So how much of a representation do you think the samples, because like you said, I think most people would probably come in because they are not happy with if they're pleased as pie, then like really why go searching for any further information? So how much of what you experience do you think represents the supply as a whole versus a sub-selection of it?
That's a difficult question to answer because, like you said, most people do test due to adverse reactions. So I get a lot of samples that are associated with like overdoses or something they didn't expect. So I think that does skew what I see. But at the same time, I do get a good range of what is in the supply because me and my coworkers do tend to go out and talk to the community. We see what people are currently using, where they're currently buying, where the most popular spots are. And then we try to get samples from those areas so that way we can better understand the supply as a whole and not just what supply is causing like adverse reactions. So it's a little difficult to answer. I do have a good kind of understanding of the supply as a whole, but at the same time, a lot of the samples I test are skewed towards more like extremes.
Now, let's do this purely in a hypothetical way. I mean, it seems like the best of all things would be to get some funding for someone to just go buy a random sampling on the street to get a real representative. Has there ever been any thought of teaming up for some form of sweep to get a general idea of what's out there?
Yeah, try to stay away from the legal aspects because, like I said, drug checking in general in the United States is a very gray area that's iffy. But we have talked very in depth about like funding for this because it's not highly funded. And a lot of people don't fully understand like what we do and how it helps people in general. They just like brush over it. So they're not as inclined to give funding to it. And when they do give funding to it, it more goes towards like salary. It goes towards the machine itself, which is like 50 grand, 60 grand. And like technical aspects, test strips, like things like that we need for the drug checking program. But like you said, that would be amazing. I think the New York City Department of Health has actually done gift cards at one point. So there has been a lot of talk about funding to get samples. But at the same time, there's pros and cons. So there's only so much we can do. And that also would set us up for more legal, like gray area, like I said.
Yeah, that makes sense. Before we get into the individual agents that are adulterating the opioid supply, I'm just curious, you might have more. I'd love to interview an actual high-level drug seller. That would be amazing. I'd get a reel from the horse's mouth, but you're the next best thing. Why are they adulterating? With the advent of fentanyl, it's very shippable, easily transportable, easily producible. Why are they messing with what seems like a real step forward in the chain from heroin, which was very difficult, to fentanyl? And yeah, there's all sorts of problems associated with it, but it's very clean. It's very easy. Why are they sticking other crap in there?
My answer for this is really long, so I'm trying to think of like
Let it be long.
Okay, so I'll answer it the best I can, like the shortest way I can. So basically, every single time the adulterants that we see more commonly are in the opioid supply. We do not see adulterants really in the crack supply, the coke supply, the meth supply, ketamine, like things like that are really rare to find adulterants in. It is primarily the opioid supply that's affected, and it's affected really rapidly and really intensely. So it changes really fast and it's very volatile. And the reasons for that, like there's a few different factors, but a major reason for that is the government's crackdown on opioids specifically. So every single time there's a huge seizure of opioids coming in, or every single time that there's a big crackdown on a certain component like fentanyl, I know that is going to affect the drug supply. Because at the end of the day, there is always going to be sellers and there's always going to be buyers. They can't crack down on fentanyl and get rid of the fentanyl supply or production, and then that just ends people using drugs and people selling drugs. They're just going to find a new component to add to it, to take the place of fentanyl or to add to the fentanyl, to stretch it more. So every single time that there is a big crackdown or like something happens like that, they just find something more risky to take the place. Which is why I'm like really heavily in support of a safe supply, because if you had safe supply, that would be a lot better for people using and people selling. There would be a lot less risk. There would be a lot less adulterants. Like Xylazine and medetomidine became so popular because of the crackdowns. I had a bad feeling when fentanyl precursors from China started to get banned and all of that stuff started happening because we started to see a decrease in fentanyl. And a lot of politicians started celebrating the decrease in fentanyl. But I knew that decrease in fentanyl was going to lead to more risky supply, so I had a bad feeling. And of course, xylazine, medetomidine, and a whole bunch of other things that come along with it then started popping up. And now we see one of the most risky opioid supplies we've seen in a long time, maybe ever. Like you said, heroin itself is associated with a lot less risk than what we see right now. A lot less health complications, a lot less overdose risk. And that sounds crazy to people who have no drug knowledge, but it's true. If people could go on the street and buy heroin and they knew that they were buying heroin, they knew the percentage of it, they knew the purity of it, they would be able to use a lot safer. They would be able to implement harm reduction policies into their use, and they would be able to know how much to use. They would know what they were using, just like how people drink alcohol. When they buy beer, they know the percentage of alcohol. When they buy wine, they know what they're buying. They know the percentage of alcohol. They know how much they can drink. They're able to pick exactly what they want, and that is harm reduction in a way, and that leads to people drinking safer. So, like, we see a lot of adulterants due to the drug war and the crackdown on the opioid supply for sure.
That makes so much sense. And at the end of this, I want to talk more about harm reduction and the stuff you just spoke about, because I'm firmly in support of everything you've said so far, and I'm sure there's much more to add to that. Let's save that stuff for the end, in like where we could go if we had a utopian vision of this. But let's talk a little bit more about the adulterants. You've given now a real understanding to me of why it happened. So you're saying if we weren't doing these fentanyl seizures, we'd probably just have fentanyl-based products without the adulterants. And it's really a lack of fentanyl or other things that would make the opioid backbone that cause the supply chain to actually add all these other things like veterinary tranquilizers to the mix.
Yeah.
Okay.
I think part of it is, of course, they want to make a strong product, but it's definitely associated with the drug war because other substances do not see the level of adulterants and things like that that opioids do. And the drug war, it focuses so much on opioids particularly.
So then let's talk about the new wave of adulterants. Let's start with xylazine, right? Which really doesn't exist to any significant amount in Pennsylvania, Philadelphia, which was I think the real epicenter of this. Are we still seeing xylazine in the Bronx?
Yeah, we are. So xylazine percentages in the Bronx have decreased, but it's still present. We still see it in the opioid supply, just not to the level that we were seeing it, say, a year ago. Actually, medetomidine has surpassed xylazine from what I see.
Okay, so tell us a little bit about xylazine. It's a veterinary tranquilizer. They're putting it in there to make up for a lack of fentanyl, is your supposition in most cases.
Kind of, yeah.
Is there more?
Can't say their exact thought process, but yeah,
Sure.
fentanyl percentages have decreased. Heroin is a lot less accessible. Fentanyl is getting to be less accessible and easy to produce. The precursors for fentanyl are getting less accessible, and xylazine was increasing around that time. It also makes a much more potent product. It's very sedating. So that would be one plus to it, to adding it to it. But there are people who don't like that high at all. A lot of people come to me and they don't like that sedating feeling. That's not why they like to use opioids. So it's interesting because some people do like it, some people don't.
That was going to be my next question. You anticipated it. Is a lot of the people that I speak to, they're looking for the euphoria. They're looking for that hit of bliss, right? And so is xylazine hitting that? And it sounds like from what you say, no, it's just basically having a benzodiazepine type effect.
What's funny is we also see a lot of benzos in the supply as well right now. That was a big trend. But yeah.
Yeah. So the high's not as great for people that are looking at that classic heroin or fentanyl high. And then the side effects are not great. Now, the side effects of xylazine were really soft tissue based.
We saw it on a really wide scale level at the center I work at. So we really increased our wound care level, our services for all of that, because we were seeing the side effects of xylazine rampant in the Bronx, definitely. But I think that the South Bronx can be really an epicenter, like what you said, where a lot of the trends of the drug market, they start there.
Yeah.
And then they make their way to other areas of the city and other areas of New York. Philly and the Bronx tend to be where I see supply trends really start.
Yeah.
And xylazine definitely hit our area really bad.
So what was it like when that was a large percentage of the opioids out there? So patients were coming in with what?
A lot of people were coming in with what they were sold as heroin or fentanyl, and I would test it, and it would be xylazine, of course, with heroin or fentanyl or both. But because we don't really ever saw xylazine by itself, it was always in combination with an opioid. But yeah, there would be xylazine in there, and they were usually not happy to see that. They did not want to be using tranquilizer. They either didn't like the effects of it, they thought it was too sedating, they thought it was too strong. And another worry of theirs was, like you said, the side effects. They saw a lot of soft tissue damage. We saw a lot of wounds that needed severe wound care, and they weren't going to the hospital. They weren't seeking out medical care. People were experiencing it in the Bronx a lot, but a lot of people were really hesitant to seek out medical care. So a lot of people were coming into places like harm reduction centers, and they would have really severe wounds or even necrosis at some points, and they didn't want to go to the hospital to seek out medical care. So we were trying our best to implement as much wound care as we could in a field on the frontline level, so that way people could get some type of medical care for their wounds before they got too severe. We would encourage people to go seek out medical care, but I think they were afraid of some of the stigma that they would receive, especially since xylazine was so stigmatized and like the wounds were so bad. And I think they were also afraid too of going into a hospital setting and say they have to be admitted, and then they're admitted into a hospital for maybe 2 weeks. They don't know what the doctors are going to do to them. They don't know if they're going to need amputation. They don't know how severe it is. So they were afraid of that reality. They were afraid of the judgment. They were afraid of the stigma. And they would also have to detox while there because they wouldn't be able to get their substance of choice. And all of that is really scary to someone who's going through all of that.
I wonder, now that you're saying it, it occurs to me that there might just be more savviness in the Bronx, and they might have the connection with these soft tissue injuries and whatever opioid supplies out there. And in some of the other places, unless the patients are actively knowledgeable about this, the docs treating them may not make the association that these horrible soft tissue injuries are actually from an adulterated opioid supply.
Highly possible.
Yeah, because it's just not spoken about very much. In all of my friends in Philadelphia. Hey, folks, but you know we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening. All about this stuff, but when you speak to people in most of New York, it's not on the radar screen. That's really why I'm doing this podcast, is I think unless you're in a place with a high prevalence, you might not even know. All right, so we're saying xylazine's mostly... Were there other problems with xylazine, or that was really the big one, is the soft tissue stuff?
I think that was the biggest thing that we saw with xylazine associated. The other issues, of course, were like increased risk of overdose, increased risk of respiratory depression while using, heavy sedation levels. People were very sedated. The way we saw overdoses started to change. Like the way overdoses were happening started to change, and the way we responded to them changed. Definitely the tissue damage was the worst.
All right, but that's fallen by the wayside, and now we've gotten something even worse in some ways in the form of medetomidine, which now, at least in the Bronx, is the adulterant of choice. Is that right?
It's very popular right now, yes.
So tell us a little bit about how you first encountered medetomidine. You started seeing it on your FTIR, and then you actually started reconciling that with what the patients were describing. So I'm super curious when you first came across this as, oh, wow, this is the next best thing.
I started hearing about medetomidine, of course, from harm reduction workers in Philadelphia because they saw it first, and then it started appearing here. But of course, when I start seeing it, it's already in the supply. Just like with xylazine, it's already in the supply. By the time it's brought to me, then I know that it's already out there. And when I first started seeing it, actually, I didn't see it on the FTIR because the thing with the FTIR is it's infrared light spectrometry. So it casts a spectrum, and then I read the spectra and I try to pick apart the components. And a lot of that has to do with what I see, but also drug knowledge. So if I'm not looking for medetomidine and I don't know it's there and it's very potent, so it's in a very small amount, I'm not going to be able to see it and pick it out on the machine. So I didn't see it on the FTIR at first. It actually started appearing in our lab results because we do confirmatory testing with GCMS and DART-MS. So they started sending back lab results that contain medetomidine. And that, of course, was a huge alert for us. So we tried to put out alerts to community members to let them know it was in our supply. I compiled a lot of education on medetomidine, but of course, there was not a lot of education on it in humans at that time. So it was up to us to build the awareness about it. And that's why when I say people bring me samples and they let me know the effects that it had and all of that's super important in drug checking. It's not just putting the sample on the machine and analyzing the components. What they bring to me and tell me about it helps build what we know about its effects on humans. So that way we can understand it better. So like people were bringing me samples, they were saying they were very sedating, like they were knocked out for hours. People were blacking out. People were reporting hallucinations, lights behind their eyes, hallucinations, aggressive behavior from people that I've never known to be aggressive in their entire lives, like just out of character behavior, things like that. And I thought that was very odd and out of place. So when we got the lab results for those samples, they had medetomidine in them. So I started tracking all of the user reports for the samples that contain medetomidine to build a whole analysis of what we're seeing in medetomidine samples and how that's affecting the user reports of those samples to better understand how medetomidine was affecting humans. We also started seeing overdoses a while after people used, which was pretty uncommon for us because as a harm reduction center, we do see overdoses and we're usually the first responders on those overdoses. So we're able to treat them right away. We're able to respond right away. And then we are also able to see what they overdosed on if they're able to let us test it, which is hugely useful because it helps us build overdose protocol. And we started seeing people overdose 30 minutes to an hour after use, which is very unusual when people are using fentanyl. They usually overdose pretty fast. So we knew that something was up there. We started seeing people very sedated, but that when we checked, their pulse would be normal. Their oxygen would sometimes even be normal, if a little low. And they didn't need Narcan. If anything, they might have just needed to be monitored for a couple hours or put on oxygen, and they would be fine. So we just saw really odd levels of sedation like that. These are things that we started seeing. We also started seeing a decrease in the wounds. So where before we were really heavily focused on wound care, and that was a huge problem in the people we see. Now it started to decrease. We started seeing less of the wounds. We started seeing that kind of go away a little bit, and we started seeing the other things that I mentioned really become a huge prevalent issue.
Now, medetomidines overdose is a pain in the butt. They can get bradycardic, they get a little hypotensive, but that's really not the true problem. We can monitor those patients. They generally just need to be watched. They don't need that much supportive care. The withdrawal is the true problem. This is like an ICU level withdrawal. They need to be put on extended dexmedetomidine drips, usually, or clonidine protocols. And they've filled up the Philadelphia ICUs to the point where there's very little space for other patients. And you might have an idea just from talking to your various folks you help out. How many uses? Have you made any connection between how many times you have to use this and these severe withdrawal syndromes?
It's going to be really dependent on the person who's using, their tolerance levels, the amount of times they use. But from what I see, if they're using smaller amounts of medetomidine and it's not as common, I've seen people be able to get off of it without severe hospitalization by going to detox, getting on methadone, clonidine, things like that. But for people who have been using larger amounts for a long time or a more extended time, and also this is really dependent on the individual as well, they tend to need the hospitalization aspect more. And people have been really hesitant to go to the hospital for withdrawals, in my experience, which is shitty because it's what they really need to help them through the withdrawals because they can be really excruciating otherwise. And then the other problem, of course, that we see with medetomidine withdrawals is it's not just that they're withdrawing from. It's opioids. It's sometimes benzos. It's all of the things in the supply at once. I was talking to one person a couple weeks ago, and she said that she can only use one supply. She can only pick up from one person. And if she picks up from anybody else, she's still really sick. She's still detoxing. And when I tested the supply that she was using, it had 13 to 15 different components in it. So I had to explain to her, like, she's at that point dependent on that specific cocktail of things. And when she goes to use a different like supply, it's not going to have that in it. And she's withdrawing from that specific cocktail. So people aren't just withdrawing from heroin or fentanyl or medetomidine. They're withdrawing from an entire cocktail of things that are in the supply right now, which is really risky because we didn't see opioid like that before.
Okay, if I was going to be cynical, we talked about one of the reasons why is they're just the precursors are not available. But what you've just said would be another reason for adulteration that in a truly Machiavellian approach to drug supply, you could argue if you had a substance that was incredibly addicting that had no effects whatsoever, you'd want to adulterate your supply with that so that they could go to your competitor and have just as much fentanyl in it and it would not in any way ameliorate their desire and need. Do you think that plays any role in why they're cutting with these agents?
Yes, it depends. So, like, when I look at the components in the supply, I usually see a lot of them are added for a reason. The people who are adulterating the supply are not like the street level dealers. They're not the people on the corner. They're not the people on the street, which I think is a really popular misconception among people who don't really understand the drug supply. It's people at a much higher supply level. By the time it hits the city, it's already adulterated. A lot of the adulterants that I see right now are definitely added for a reason. Like medetomidine burns really bad when you sniff it or inject it. It is associated with really bad burning sensations. So due to that, we started seeing a lot of cuts like procaine, lidocaine, tetracaine, benzocaine, all of that stuff added in to try to numb the burning. So then now you have another cut that's added or two more cuts that are added. So it went from being just heroin and mannitol and fentanyl to now being like heroin, mannitol, fentanyl, medetomidine, procaine, lidocaine, tetracaine. And then there's other stuff in there. Like now they're adding caffeine. They want it to get to the right color, the right consistency. That's a bulking agent that we see a lot now too, because people associate like that tan, like powdered dope with good heroin. So they're cutting it to make it look like that. Then we also see quinine added sometimes because quinine creates that itchy feeling that like heroin gives. So they'll add quinine because they're not really having a lot of heroin in there anymore. And they think, oh, if I add that itchy feeling, people might think I have good supply. So now there's like all of these components mixed together. And like you said, also too, it does have to do with the fact that once they start using things like medetomidine and xylazine, it is really hard to switch to another supply that doesn't have it because they're going to be detoxing from that and not even know it.
Oh, man, that's crazy. Heroin's a pain in the ass at the supply level. Let's say we had just pure weight-based fentanyl products that some people knew what they were getting, just as you were alluding to before, that it's not this huge variability between batches. Would people still want heroin as opposed to the fentanyl products? Is that a better or more desirable high?
I think that definitely depends on who you ask. I think that some people still want heroin. I also have some people who now they build a tolerance and heroin just does not like get them like it used to. I noticed that a lot of the older crowd, they really still like heroin. That is what they grew up on. So that is what they still want. They're not as inclined to use fentanyl or tranquilizers. They want heroin. I do notice that a lot of younger crowds, they're used to fentanyl at this point because they were not really there for when heroin was just heroin. So like they're more inclined to want like fentanyl because that's what they're used to. Also, when someone has been using fentanyl for a long time and they build that tolerance, and yeah, they're going to probably want fentanyl unless they're able to like safely move down to heroin because fentanyl is much more potent. So like when they use the heroin, they're not going to feel it as intensely as when they use fentanyl. A lot of people I know though, they do prefer the both mixed together.
Mm.
So like a lot of people will tell me that they'll mix it if it's not already mixed.
Do you have any inkling what's next? What's going to be the next one we're talking about after medetomidine?
I don't know. I really hope nothing. I've seen some stuff pop up that's scary, but we haven't seen it on a widespread level yet or anything that's to be concerned about. So that's good. We do see a lot of benzos in the supply that pops up. We see things like phenibut that we've noticed that's kind of like also popping up instead of benzos in the Bronx supply. I don't know if that's popular in other areas as well. We see like promethazine and Benadryl in there as cuts, very odd, but that's been added. And right now, I feel is one of the most potent, like, kind of anesthetics there is.
What about
but it is
edazines?
warning. Yeah, so we haven't seen those in our supply yet, luckily. I know that in other areas of the United States, they are seeing those. There's a lot of different nizines that are can be added, but we have not seen them in the Bronx yet. From some people that I've talked to in New York City, they said that they mostly see them in the pressed like M30s and the pressed Oxy 30s that are on the street.
Yep.
They said that they've seen them there a few times, but in the dope supply, we haven't seen it yet. I'm not sure why. I'm not sure if that maybe just like suppliers are staying away from them, if maybe they're not as accessible, if maybe they're not like as cost effective. There might be a reason why they're staying away from them. I'm not sure. Or they might just start popping up soon. I do test for them. So I'm like aware that they can potentially be in there. I have test strips for them and I can look for them on the FTIR and send them in for lab testing. We just luckily cross my fingers have not seen them yet. I would almost not really be too upset about if they started taking the place of medetomidine.
Sure.
They were added in addition to medetomidine, of course. That would really increase the potency of the like already really potent product because we already have benzo, xylazine, medetomidine, heroin, fentanyl dope out there right now. But the good thing about them is they're reversible by naloxone, which is great. You can use methadone or subs to get off of them, whereas medetomidine, is like not in that boat. That could be next.
It would seem like the pills could be a more standardized supply. It's done above the street level dealer level. They could standardize it. They could give the equivalence of an oxycodone, even though they're using different agents to get there. Has that been your finding, that people have less likelihood of having severe overdoses from the oxy analogs because that they are standardized to some extent, or is it still the grab bag of risk that is the dopes?
I think that in one way, you're right that it can be a little bit less risky. Because, like I said, the dope supply sees more adulterants than the pressed oxy supply. They usually use like pill fillers, sometimes Tylenol, or lidocaine, little things like that. There's usually fentanyl. Sometimes we see BTMPS in there. But yeah, it's usually like less cuts overall, it's less chaotic than what I see in the dope supply. The only issue I see with those pressed pills is that one of them might vary very extremely from the other one in the amount of fentanyl or like the potency of them. And there also can sometimes be hot spots because they're not pressed as well as like a pharmacy or something would press them. So like you can break the pill in half and the one half is very weak or not as potent and then the other half is very strong, which can lead to overdoses. Or like you pick up one batch from someone else that is way more potent than the next batch. But overall, I think there's less adulterant in the M30s from what I see personally.
All right, so let's have a hypothetical vision here. You're made drug czar of the United States, and all of the Puritans are left out of the process. You get to go with whatever you like in terms of passing laws to reduce harm, and with the understanding that prohibition didn't work. We're not going to get to the point of just outlawing drugs. People are going to find a way. So what would be a utopian way of reducing harm?
How I feel about it personally is definitely a safe supply. I think that is like the best thing you can do in regards to harm reduction. I think we still need, of course, like what we have harm reduction programs where we have HIV testing, Hep C testing available for free, where we have treatment available for free, where we have syringe exchange programs and people can access sterile syringes. They can access new sterile pipes every use. They can access chore mouthpieces for the pipes if they share it. They can access clean straws and sniffing kits, and they can access all the like education and awareness on how to use these things and reduce risk while using. They can access naloxone for free. They get trained on naloxone for free. They're able to, I would love more OPCs, like overdose prevention centers. That would be amazing, where people can use under the care and watch of like medical professionals and harm reduction workers. So if they do overdose or they have any adverse reactions, we're right there. We're able to respond immediately. It would greatly decrease overdose deaths and like risks associated with use. That would be amazing. I don't know if that's going to happen, but in a utopia, I would love that.
Sure.
And then a safe supply, I feel, is just the best way to do it too. If you could walk into a store the same way that kind of like they're doing with medical marijuana now or just marijuana now, like you can walk into the store and there is someone trained behind the counter who knows like about the product. You can go in, you can ask them about it, you can talk to them about it. They can give you advice. They can give you tips like, hey, I'm coming in because I want to use opiates for chronic pain. What would be the best opiate to use? This is my issues. This is what I'm looking for. This is the high I'm looking for. And then the person would be able to steer you in the best direction. You could be like, this is my tolerance. This is what I usually use. And then they have different products. You could see what you're buying. You could see like the purity level of it, what's in it. And then you're just able to understand better what you're using it for, like what you should be using, like all of that type of stuff. And you still would be able to access like harm reduction tools, methods, awareness, and all of that. And then, of course, we still need to fix like the rehabilitation programs that are in the United States. I think that there's a lot of issues with rehabs and like the way that rehabs and detoxes can be run and the programs. If we had a little bit of a better, I don't know, a way to do that. But I think that a lot of rehabilitation centers aren't always run the best way that they can be. I think a lot of them are profit incentive where they shouldn't be. I think that a lot of them are just AA and A focused and like complete abstinence focused. Whereas if we could have rehabs that kind of focus individually on why someone is using the best tools that they have to use and meet them where they're at, like we do in harm reduction. So that way, when they're in rehab, they can focus on what has caused them to use, what goals they want to reach, how to reach them. And then they're met with the best treatment methods. If they want psychiatric care, they're able to get access those resources right in rehab. If they want detox or medication assisted treatment, they're able to access that right in rehab. And then when they're discharged from rehab, people can follow up with them. Like they can follow up with resources instead of just being discharged into the street, which I see a lot. And they're discharged into the street. They might have one follow-up appointment and that's it. I think that it would be like a lot better if maybe we could like do that program a little bit differently, if that makes sense. I don't know if what I'm saying is kind of making sense.
I think it's totally making sense.
Yeah.
And from my personal views, I think I'd agree with a lot of that, and especially with the safe supply. Let me play devil's advocate and try to come from, I think, the opposition and see. So when this has been tried with cannabis, the usage went up dramatically with people who may not have ever gotten involved in cannabis now potentially using on a far more frequent basis. Do you have that same fear if there was a safe supply of opioids, people who were naive to opioids maybe trying it, it's opening the door. Oh, now I don't have to deal with shady drug dealers. I could just go into a beautifully lit store. And then with the abuse potential of the opioids, do you think it would have a net negative to make this more accessible?
My answer might be a little odd, but I don't really think that is too bad of an issue. I think that this is me. I think that I have a very harm reduction focused mindset. So I think that drug use itself is like a morally gray area, and there's not actually anything too wrong with, like, it's not a bad thing to use substances. I think that that necessarily wouldn't be too bad of a thing. I think that when we focus on substance use, I think that our goal should be to reduce any risks or effects like that are negative associated with substance use. Make sure you're using in the most healthy way you can. Make sure to reduce the risk of overdose. Make sure to reduce fatal or non-fatal overdoses and all of that. And I think that a safe supply would really do that. So even if more people are technically using opioids, they're using opioids in the safest way possible. And I think that risk would be worth the benefits of a safe supply. I think that the risk associated with maybe more people might just want to use opioids.
Yeah, I love that. All right, we're getting to the end of the amount of time I'm willing to suck out of your life. What have I missed that we should have spoken about that we didn't?
I think that people definitely need to be aware that methamphetamine is in the supply. It's going to heavily depend on the area, but New York definitely sees it. I think a lot of people don't know what it is or that they're using it. In the Bronx, out of the samples I test, it was in about 1/3 of the dope samples that I tested around 3 months ago, and that amount has greatly increased since then. And I warn people right now that if they're using opioids or the dope supply on the street, that there is a good chance that they're going to use methamphetamine at some point if they're not already using it. And I think people need to be aware of that before they go into detox blindly or before they just are set into really bad withdrawals. I think people need to know that there's benzos in the supply because the withdrawals that we see with those are really bad as well. Seizures, death, and people didn't even know that they were using them. A lot of people right now are going into detoxes and stuff like that, and they're like, oh, they found no heroin in my urine. They're very surprised by that because they thought they were using heroin. We still do see heroin out in the street. I see a lot of samples that have heroin in it, whether it's mixed with a lot of other things or it's just heroin and say one cut and a little fentanyl. We do see a lot of heroin. It's just definitely less common than it used to be.
Let me ask you this question, because as an emergency doc, I want to give harm reduction strategies to my patients who actually came in with overdoses. So what would you recommend to tell them? At this point, are fentanyl test strips even worthwhile? Because you should just assume whatever you're using has fentanyl. Are there fentanyl test strips? If there were, you just copped. You're not going to really want to throw out your supply. So what would you tell them if you were next to
I
the ED
actually love
doc?
that question. I think that it would be really amazing if doctors were more like harm reduction focused, especially the people coming in. And yes, there are medetomidine test strips. They do have them. They actually work very reliably from my experience because I'm doing confirmatory testing. I use BTNX medetomidine test strips for my work, and they're pretty reliable. They're pretty good, and they could pick up trace amounts of medetomidine, which is amazing. So they're out there. They are very accessible. You could go into a harm reduction center and ask about it, or you can use drug checking services, or even the hospitals could add them in stock to give out like fentanyl test strips. Like you said, fentanyl test strips, opioid users aren't as interested in them anymore because they're pretty much assuming at this point that most of their supply has fentanyl in it. And that's a good assumption. But medetomidine test strips, I think, would be more intriguing to them because they aren't as aware about that, and they would be probably more helpful. I also, like you said, they're not going to just throw out their supply. They just spent their money on that. They just bought that. Some people might, most people aren't going to. But I think that we can increase harm reduction tips associated with medetomidine use, which one big thing that I suggest to people is the medetomidine high tends to creep up a little bit as like the fentanyl rush and the high hits very instantly. When you use fentanyl, especially when you inject it, but even when you sniff it or smoke it, you feel that high pretty instantly. And that right away, that is like the highest you're going to get. So if you overdose, you're going to overdose pretty quickly. If you're very high, you're going to be very high pretty quickly. So people use, like we tend to tell people use a little bit, start slow. You can use more, but you can't use less. So start slow, gauge the high, and then use a little bit more. And I think that's still a great tip to give to people. But the issue that we see right now is, like I said, medetomidine kind of creeps up with the high. So they might use, and then 20 minutes later, they still feel fine. And then they're going to use again. And it's just going to hit them all a lot later because people are overdosing like 45 minutes, an hour after they used. So what I tell people now is I warn people about that. I tell them use a little bit. And then especially if they're sniffing or smoking, wait 30 minutes, 45 minutes. See how you feel then. Don't just start slow and then 20 minutes later use again. Start slow and really go slow if they're able to. I know a lot of people are going to be in withdrawal, so they're going to want to get unsick as fast as possible, but that is like a really great tip if they want to reduce risk associated with it. And another thing too that I suggest to people is, like I said, medetomidine burns when you sniff it or inject it. And yes, they're adding procaine or adding lidocaine, so it might numb them, but a lot of people are still reporting burning sensations. So if someone uses and they feel that unusual burning sensation, that is a good indication that there might be medetomidine in their supply. And that is a good indication that they should take harm reduction precautions when using. Test strips are available for them to use. Drug checking services are available for them to use. There's a lot in New York City. We're really lucky with drug checking programs in New York City. I really recommend them to anybody who's using opioids right now. And a lot of people I suggest is to switch sniffing or smoking if possible instead of injecting, but that's something that people might not be willing to do. And of course, to carry Narcan and to not use alone. If they have a trusted friend to use with, if they could go to a center to use, we have OPCs in the city that they can go to just to be around someone else and to stay with someone else. Because like, as long as they're with somebody else, the chances of their overdose being fatal is a lot lower.
Oh, those are fantastic tips. Courtney, I can't thank you enough. This has been fascinating and educational. I've really enjoyed this conversation. Thank you so much for your time.
No, thank you. This is fun. I enjoyed it.